medicine. He is received his BA in Houston at Rice, and then ran off to Vanderbilt for medical school, our competitor in the middle part of the state, and back to Houston for residency in internal medicine, and back to Vanderbilt for fellowship in hematology before working at Cincinnati Medical University, South Carolina, Vanderbilt, and back here.
In Kentucky.
Has published somewhere in the neighborhood of 79 or 80 peer-reviewed articles, about 48 or 49 chapters. I'm not quite sure if he ever sleeps in combination with his administrative time. So he's going to talk to us this morning on anemia and pregnancy. And I really appreciate you all giving him your undivided.
Thank you. It's a pleasure to be here this morning. I'm going to talk to you about anemia in pregnancy from the perspective of a hematologist. For the last couple of editions of the Wintrobe textbook of hematology, I have found myself writing the chapter on the anemia in pregnancy. Again, the perspective I'm going to present is how one looks at it as a hematologist, but also with some informed also by the literature. There are a few things I'm not going to talk about. I'm not going to talk about management of sickle cell anemia in pregnancy. First, I'm not sure there's that many sickle cell patients around here. When I was at the University of Kentucky before I came here, I was one of the few hematologists who would actually take care of adults with sickle cell disease, and I did a fair amount of business in the sickle cell anemia pregnancy thing. It's an interesting topic, but it would be a lecture in and of itself. And it's one of these lectures that you might have to rewrite on the morning because what you do changes with a fair frequency. Okay. So disclosures. I'm a member of the American Board of Internal Medicine Hematology Examination Committee, and I am required as a result of that to state anytime I give a presentation that what my presentation does not reflect the activities of the committee, and it cannot be reused in a board review course, particularly in internal medicine, but in any event. So mandatory disclosures. I am a consultant. My only commercial activity is that I'm a hematology consultant, mostly for safety issues, on a clinical trial that's a joint project between the NIH and Sanofi. And the topic is completely unrelated to the topic of this lecture. I'm the editor of the Wintrobe hematology textbook. The figures in the tables I'm going to show, mostly tables, I'm the author of them. When it isn't something I put together for this talk, I'll cite the source. So I always enjoy talking about anemia, and the thing I like about anemia is that anemias are the disorders in which what we used to call the internal medicine model of medical thought is most clearly applicable, which is you make a highly specific diagnosis, and that dictates your therapy. My wife is an infectious disease physician, and she tells me that infectious diseases is where the internal medicine model has its most pure application. But of course, they treat things mostly on the basis of syndrome. At least a lot of what they treat is on the basis of syndromes like community-acquired pneumonia and not on, for example, culture results. So I still think I'm better off, although I don't say it around the house. First, just want to comment on what you will see most of, which is the physiologic anemia of pregnancy. As I was coming in this morning, I was thinking, what I say here is one of the few circumstances in adult medicine where anemia is not the result of a disease or some kind of homeostatic imbalance, but is a purely physiologic phenomenon. And I was trying to think if there actually are any other circumstances in adult medicine where this happens. There is something, an entity called, that you see sometimes in runners and other kind of aerobic endurance athletes, where they will have a very mild reduction in their hematocrit as a result of having a somewhat expanded plasma volume, in fitness. The reason that that's probably not truly physiologic is they also have some not clearly understood hemolytic processes going on as well. But anyway, the other circumstances, all the true physiologic anemias are basically in y'all's department, because the other one is the physiologic anemia of the newborn. But in any event, the physiologic anemia of pregnancy is, as you know, is normocytic and normochromic, and it's stable throughout the third trimester. It's usually about 11 grams, at no lower than 11 grams in the first trimester, second and third no lower than 10, and it generally becomes apparent around the 7th to 8th week of pregnancy. What is the basis of it? The basis of it is two things. One is an increase in the total blood volume, largely from an expansion of the plasma volume. But later, which begins around week 6, it can go up to 40% of baseline. If you have preeclampsia, your plasma volume does not expand as much. The red cell mass, starting in the late first trimester and plateauing early in the third trimester, increases 15 to 25% also. So your total blood volume increases. Again, most of it is your plasma volume increasing, but there's also an increase in your red cell mass. This is driven by increased erythropoietin production as part of the response to pregnancy. So even though the hemoglobin drifts downward, in fact, they have more red cells than they had before they were pregnant. And again, if you're, from the perspective of a hematologist, a normocytic anemia, certainly above 11 and probably above 10 in late pregnancy, wouldn't necessarily require investigation in a healthy, otherwise healthy circumstance. The other point, of course, is that if patients were compliant with their supplementation, most of the nutritional anemias would not be a problem. But my wife didn't take her she took her prenatal but didn't take her postnatal vitamins. I saw a patient Wednesday who was being seen for fairly significant iron deficiency, who was kind of in the same situation. And so if people did what you told them, life would be better. But they don't. So anyway, so part of the situation that you deal with, obviously, is that roughly 30% of women of childbearing years are iron deficient, whether anemic or not. Now, this obviously has some significant issues for the time of pregnancy. It actually has issues for students who may be present in other circumstances as well. For example, a lot of laboratories report two ranges of ferritin values. One range for women, which may go down as low as 6 as the lower limit of normal, and a range for men where the lower limit of normal is generally somewhere in the 15-ish range. It varies a bit from lab to lab. The reason for that is not that a ferritin of 15 in a man represents a different amount of iron than it does in a woman. What it is that a high percentage of women who are not anemic and are otherwise entirely healthy have reduced or absent iron stores. So the normal population on which that's based contains a lot of iron deficient folks. So what's the iron flux over life? Well, during menses, the average woman loses 25 milligrams of iron per month. Obviously, periods are heavier, you lose more. In late pregnancy, you need a lot more iron than that. Iron is regulated essentially at the absorption level. There's no real regulation of iron. You can't. If your iron gets, it isn't like fluid where you get too much. You pee it on out. You get too much iron, you don't pee it on out. It stays, and you lose. Women lose it in menses, and of course in childbirth. During pregnancy, because they are contributing iron to the fetus, it is much higher demand. What an average newborn represents, it's generally considered, is something like 800 milligrams of iron. Obviously, all that iron came from mom. They didn't absorb it magnetically from the atmosphere. On the next slide, which is some Scandinavian literature, I'm going to show you that based on sort of estimates of iron intake during pregnancy, those authors at least feel that what you need to start out pregnancy with is to have at least 500 milligrams of iron on board. And they argue if you had 500 milligrams of iron on board, you might not need supplementation. So in any event, so what happens over the course of pregnancy in terms of mom's iron? The iron is transport across the placenta is regulated in a way that the kid gets all of mom's iron. Whatever iron the kid needs, it pretty much gets if the mom has it to give. So this is a study which I meant to put in the citation from the 1960s by Van Leeuwen and colleagues, and it's something you couldn't do nowadays. What they did was they took a large number of healthy pregnant women and they did bone marrows on them all before and after. And what they found, now bone marrows are safe, but it's just unpleasant, and you probably couldn't get folks to do it. What they found was that if women who do not take iron supplements, 84% of them have absolutely no detectable iron on their bone marrow after delivery. If you look at women who do take iron, 84% of them had detectable iron after delivery. The reason it's not 100% is probably because there was some level of marginal iron stores present at that point, or there may have been some complications. So the frequency of iron deficiency is higher in the less developed world and among economically disadvantaged folks. So what about this? This is a study from Scandinavia from several years ago, but it shows a nice distribution of things. The authors proceeded on the assumption, which is not unreasonable, that in a healthy person without ongoing inflammation, a ferritin around 70 represents having about 500 milligrams of iron stores. And they thought, based correlations with bone marrows and some much older clinical studies when they would do selective phlebotomy on people to see how much blood they had to take off to make them iron deficient. Again, studies you don't get to do anymore. That about 30, a ferritin of about 30 represents about 100 milligrams of storage iron. So 20% in this study had adequate iron stores to carry them through pregnancy in their book, greater than 500. 40% were reduced iron stores, and 40% were absent. So again, a common problem leading to the issue. So what are the adverse consequences for maternal iron deficiency? There's actually some debate as to how they are. I could have frankly had a slide for each of these completely full with italicized references. This is just a characteristic one that says, yes, it has adverse consequences on preterm delivery and low birth weight. Studies from large databases from the Cochrane Collaborative that it does not. And then this is a study from Canada where they said that it might, but only that you were more likely to have an adverse consequence in pregnancy if you are iron deficient at the beginning of pregnancy, which reinforces the point that the adverse consequences of iron deficiency result from other disorders or situations of which anemia may be a sign. So you may be iron deficient because you are economically disadvantaged. You may be iron deficient because you're GI bleeding. You may have a variety of other disorders. So the adverse consequences and outcome are not clear, but it probably is worth fixing. In terms of adverse consequences for the child, again, the child is protected to a great degree from it, unless, except in circumstances of extreme iron deficiency. It is well established, particularly in the less developed world, that an iron deficient neonate or infant is at developmental disadvantages, particularly actually neurocognitively. And things that make, as opposed to maternal anemia, things that make iron delivery to the baby in utero less good are things like gestational diabetes, which interferes with iron transport across the placenta. Okay, so how do you diagnose iron deficiency during pregnancy? Well, no, there is some variation, frankly, in iron parameters during normal pregnancy. And this, again, this is very old data because this is the sort of thing you looked at in the old days. This is not exciting enough or molecular enough to look at nowadays. So during the course of normal pregnancy, the serum iron falls and the TIBC rises. Some of this reflects increased demand and a state of what we refer to usually as iron deficient erythropoiesis when your stores become somewhat marginal. However, the usual criteria for diagnosing, iron deficiency will apply during pregnancy, again, typically because you're dealing with largely a healthy population. Apparently not in your cases, but in a lot of circumstances more generally. Acquired microcytosis, a total iron binding capacity less than 50%, a low serum ferritin, or an elevated serum soluble transferrin receptor. It's usually fairly straightforward to diagnose iron deficiency in pregnancy. If you have general thinking is that if you're going to do a single test, the single best test is the serum ferritin. If it is low, it is diagnostic of iron deficiency. If you do not have concurrent inflammation going on, it is quite reliable. One of the problems is if you have significant other medical illnesses, the ferritin is an acute phase reactant, and it will be elevated, falsely. If it's greater than 100, practically all the time, and if it's greater than 200 all the time, you have plenty of iron. But the serum soluble transferrin receptor, which is basically a reflection of the body's transferrin receptor load, which increases in iron deficiency so that transferrin can get transported into cells more rapidly and more effectively, goes up in iron deficiency. It is generally pretty reliable in pregnancy, although there is some suggestion that because they have increased red cell production, that their soluble transferrin receptor goes up normally. Although, in fact, a review from Nutritional Reviews that I actually read this morning before walking over here says that actually the cutoff should be lower for the soluble transferrin receptor. So it's easy to make a diagnosis. Now, hepcidin is kind of the hot thing that everybody focuses on in iron nowadays. Hepcidin is basically the regulatory protein of iron balance. As your iron stores increase, your hepcidin rises. As your hepcidin falls, iron absorption is increased. So, for example, in people with hemochromatosis, they have disorders that cause their hepcidin to be low, which causes their iron to be absorbed. So the hepcidin during pregnancy decreases in a way that favors iron absorption. You can't at the moment measure hepcidin readily clinically. It will be likely available within a few years. And once it becomes available, then somebody can answer the question as to whether it's actually better than like looking at the ferritin. But in any event, so you're in a situation that favors iron absorption, and you can usually make diagnosis on the general criteria. Now, unless you're bleeding, you can probably fix all this just by supplementing everybody. This is an older citation, but I could certainly find more recent ones that would say the same thing. This study, here's a study from Annals of Hematology done by the same folks who did that study I showed you a while back. And what they argue is that you could selectively supplement people if they have an adequate ferritin. Probably, you might want to, and I leave obstetric management decisions to the experts. But they would argue that if your ferritin is solidly in the high end of the normal range for a woman, you don't necessarily need to be treated with iron. And if you're going to treat iron, it's my experience of seeing consults is that most of you all probably use once daily iron. Is that a fair statement? Yeah, yeah. And this is a place where you all your iron management was on in advance of us in hematology, where we traditionally use iron 3 times a day or at least twice a day. There was a study that came out right at the end of last year, and it was actually done in young women of childbearing years who had iron deficiencies, largely on the basis of menses and pregnancy. And what they did was they measured hepcidin to see what happens when you take iron 3 times a day and what happens when you take iron once a day. And what they found is that if you're taking iron 3 times a day, you take your morning iron, everything's hunky-dory. Then around noon, when you take your iron at lunchtime, your hepcidin has started to rise, and it's going to decrease your absorption, so you're going to absorb less of the iron you take at lunchtime. And then having taken 1 in the morning, 1 at lunch, by dinner time, you absorb practically none of the iron you take at that time. And so what they demonstrated in this study was that, in fact, in that population, once a day iron, particularly given in the morning, is much more effective, or is equally effective to giving it 3 times a day. So I'm actually, certainly with sort of uncomplicated iron deficiency, particularly in women, I'm doing that in my practice now. And so you all were ahead of the game. What sort of iron should you give people orally? The answer is there's a couple of things that matter. Whether it's ferrous sulfate or ferrous gluconate or ferrous fumarate probably is a matter of economy and tolerability. I recommend strongly against giving people enteric-coated iron to take. The reason is that the enteric coating frankly interferes with the breakdown of the tablet. There are a number of studies in the pharmacy literature which demonstrate this. And back in the old days when I used to lecture to the medical students on sort of the basics of anemia, I used to have a demonstration that I would do where I would drop an enteric-coated and a non-enteric-coated iron tablet in a glass of water on the lecture, in glasses of water on the lecture, and the non-enteric-coated would dissolve in a couple of minutes. At the end of the lecture, the enteric-coated one would still be solid. One time, I took that glass home and put it on my kitchen windowsill, and the tablet was still intact 3 weeks later. Now, obviously, your stomach's churning and things get broken up, but enteric-coated is going to yes, it increases the tolerance. It increases the tolerance because there's less iron available. Gel caps, gel-coated, perfectly fine. I also tell patients to buy the cheapest iron, if they're of any particular type of iron preparation, ferrous gluconate, what have you, to buy the cheapest, because what's the iron? Cost of iron is dirt. What makes the pill more expensive? Junk that you put in to the carriers, and most of them interfere with absorption. So I like ferrous sulfate myself. Intravenous iron, it's safe, but it's typically not needed. It occasionally is needed afterwards for severe iron deficiency in people who, for GI reasons or compliance reasons or whatever, don't do it. So you treat, important to remember that if you are treating iron deficiency, particularly orally, you need to treat until the hemoglobin and hematocrit and the MCV are both normal, and then until the ferritin is greater than 50, or if, for whatever reason of patient resources, you aren't able to follow the ferritin effectively for about 3 or 4 months, and your objective is to replete the stores. This is because you have to back up kind of the process of iron deficiency. Process of iron deficiency is, let's say, one develops a slow leak of blood somewhere. If the process of iron deficiency is, assuming you're not, losing large volumes at a burst, process of iron deficiency is that your iron is mobilized from stores slowly, and during that period, your hemoglobin and hematocrit generally remain normal, and you remain normocytic, up until the moment that last molecule of iron leaves your stores. Then, when you're only depending on recycled iron and you're still losing some every day, you're going to remain normocytic and normochromic until your hemoglobin usually drops about 2 grams below what you were at your lower edge of normal. Then, at that point, your MCV starts to fall. So what you need to do is you need to just kind of back them all the way up that tree, all the way back to replete iron stores. Now, you'd say, well, if the MCV and the hematocrit start falling simultaneously, well, wouldn't you expect the MCV and the hematocrit to get normal about the same time? They don't, because the red cell survives about 120 days. You'll generally see an increase in the MCV, but what you're seeing, if you were to look at the blood smear, is you would be seeing a population of small cells and a population of normal cells. So, okay, intravenous iron. A lot of the time when folks use intravenous iron, and hematologists do this a lot, frankly, as to anyone who prescribes intravenous iron, most of the time you kind of look and say you're using Injectafer. You say, well, it says you can give 750. How much comes in the bottle? 750 milligrams. How much are you going to give? 750 milligrams. Package insert is written, you're given 750 milligrams. And that's fine. That is what most people do. It's what I do a lot. But you probably should, before you start out, estimate how iron deficient your patient is before you give intravenous iron, because that will help you understand whether you have given enough to correct it. So there's 2 components. There's the circulating deficit, which is the effect on the red cell. The storage deficit. In women, storage is about 5 milligrams that should be per kilogram. 5 milligrams per kilogram. So you'd want, if you had a 70 kilogram woman, you would need to make sure that was 350 milligrams to deplete the stores once the hematocrit is normal. It's easy to figure out what the deficit the iron defect to correct your hematocrit is, because by an amazing coincidence, a milliliter of red blood cells contains roughly a milligram of iron. So what you do is you estimate the deficit, and the best way to do that is to take a reasonable value of normal, and I use 40, subtract the observed hematocrit, multiply, and that shows you the sort of the volume deficit of iron, because the milliliter of blood that you're looking at being low is 1 milligram of iron. Multiply it by an estimated blood volume. Normally, a blood volume in a man is about 70 milliliters per kilogram, and a woman is about 64. If you're thinking postpartum, you probably still have a bit of a expanded plasma volume, and you always lose a little bit in metabolism anyway, so I generally use 70, and this comes up with an estimate. So this will help you understand, even if it doesn't change what you dose, it helps you understand whether you gave enough to correct the deficit. So if you have a large person who has a 1,500 milligram iron deficit, if you give 750 milligrams of iron, it is not reasonable to expect that they would be corrected. And so therefore, when they aren't corrected, it's not that something was wrong, that they are resistant to IV iron. There is at least one disease where people are resistant to IV iron, but not much. And I can almost guarantee you your patient doesn't have it. But if you can do that, it would tell you, but you say, well, it isn't that they're resistant to it, it's that I didn't give them enough. So folate deficiency, again, reflects the increased folate demands. What you need, at your baseline is about 50 micrograms a day. What you need in pregnancy is somewhere between 200 and 500 micrograms a day. You don't store folate very much. Nobody has much in the way of folate stores. Folate reflects current nutritional intake. Now, in the U.S., outside of the situation of pregnancy, you don't run into folate deficiency anemia much anymore because there's so much folate in everything we eat. And if you have bacteria, it increases because it increases your folate demand and increases the likelihood of folate deficiency. Obviously, from y'all's point of view, the primary consequence is neural tube defect development, and it's important. And the reason why, of course, as you well know, it's important to be on folate supplementation, independent of any hematologic issue, is that you need to have your folate early on in order to avoid the neural tube defects, whereas late folate deficiency anemia is not going to show up until the third trimester. So if you weren't taking your folate, the prophylactic benefit for the neural tube defect will not be corrected by treatment of anemia, because the anemia won't manifest until late unless it was present before. So obviously, if you are treating with your prophylaxis, you'll prevent folate deficiency. It's relatively uncommon to actually have macrocytic anemia, and typically those are people who are already deficient. Again, nutritional deficient or absorption problems in B12 deficiency. If you're testing for folate deficiency, you also need to be testing for B12 deficiency. When I was young, I believed that you could tell them apart clinically. Now that I'm older, I know that I still believe some people can tell them apart clinically, but I don't know who those people are, and I'm not one of them. All these things about, well, if you're neutrophils or if you have hypersegmented polys, that's B12 deficiency and not folate deficiency. That's largely true, but it's not true enough to bet your patient's health on it. So if you're going to test for one, you test for both. Serum folate is easiest because it is cheap and readily available. Red cell folate is theoretically better because it's like the hemoglobin A1C. Folate is incorporated into red cells at one specific point in red cell development. So what it gives you is an average of your folate status over the previous 120 days. It's not really proven. Because of that theoretical advantage, a lot of textbooks recommend it. It's actually never been proven. It's really better for disease finding. It may be better for screening if you're doing a nutritional status study. But it's better for population screening, not necessarily better for disease finding. If you have something going on that, for example, required you to have a transfusion, or you have somebody else's blood floating around in your veins for whatever reason, all your red cell folate is going to show you is what that person's folate status was also. Methylmalonic acid, if you will confirm, an elevated methylmalonic acid confirms B12 deficiency when you have a questionable result. And there's another line cut off below this. Homocysteine tends to rise in folate deficiency, also rises in B12 deficiency, but definitely rises in folate deficiency. The problem in the setting of pregnancy is that if you have preeclampsia, homocysteine also rises there. Homocysteine is also kind of a vascular damage marker. So homocysteine is not particularly useful in the evaluation of patients with pregnancy. How are you going to treat it? Folate, 1 milligram per day. You almost always corrects it. If you have, if you can certainly, we worry a lot about overtreating folate deficiency because of studies that were done in the 1940s, actually up in Cincinnati, that showed that people who had B12 deficiency who were treated with folate in high doses developed neurologic complications. I actually used to work with the guy who had done that study in the 1940s when I was at Cincinnati. And he said, well, of course, first, there are two things to consider. First place, they weren't getting treated for their B12 deficiency at all. And second place, and second place was that they were probably getting something like 50 milligrams a day of folate. You could certainly, if someone has folate deficiency and is not responding, anemia and is not responding, you can with absolute safety go up to 5 milligrams a day. You could probably go a little higher, but I don't like to go higher than 5. B12, there are 6 million ways to give B12. This is how I like to do it. I don't know of one that's wrong. If I give it 1,000 micrograms weekly for 3 weeks and then monthly. How much do you actually need? You need 50 micrograms. You can't get it in a 50 microgram vial. You know, you would need a magnifying glass to have 50 micrograms in your syringe. It's cheap. The B12 injections, almost the cost of the glass of the vial, is more than the cost of the B12. You can give oral B12. If you're going to do that, you need to give 2,000 milligrams a day, every day. It works. Compliance is sometimes an issue. This is particularly the case in people who have underlying pernicious anemia, and B12 deficiency is not typically a normal demand in pregnancy, so they likely have an underlying pernicious anemia. But this will work even in people with pernicious anemia, but the problem is once they start to get normal, they stop taking their B12. There's a large experience with this in Europe. And that was their conclusion. Whereas people can't remember to get a shot once a month. If you're not sure if you're dealing with B12 deficiency or folate deficiency, in the setting of pregnancy, you're probably dealing with folate deficiency. But if you're not sure, use both. They're cheap, they're safe. Short of injecting the B12 into like a major organ where the sciatic nerve or something like that, there's no way it's going to hurt you. One of the nice things about B12 is that if you get too much, you just pee it on out. The consequence of overdosing someone with B12, for the most part, is funny smelling urine. It smells like those little drops you used to get for the vitamins that you get at the pediatrician's office in one's youth. Okay, there are other rare nutritional causes of anemia rarely seen in pregnancy. Zinc deficiency, copper deficiency, and selenium are the most common. When do you're probably not going to run into these. Copper deficiency looks a lot like B12 deficiency. So it'd be someone who has a macrocytic anemia, sometimes a mild neutropenia, sometimes a bit of a neuropathy, and they've got normal B12 studies. When are you going to run into these things? You think of these things in people who have had gastric surgery, particularly bariatric surgery, because usually you have to have an abnormal GI tract physically to get these things. Now, copper deficiency, several years ago, and up until within the last couple of years, was actually sort of a minor epidemic, particularly in this part of the country. And it was on the basis of one thing: false teeth. One of the common things that you use to glue your false teeth in were zinc contained zinc. Copper and zinc are transported by the same transporters, and so if you had, frequently people with false teeth do not have outstanding tissue integrity on their gums. If you're using a zinc-containing adhesive, you would absorb zinc, and you could get copper deficient on that basis. About 2 years ago, they pretty much took zinc-containing dental adhesives off the market, so that you don't see that much anymore. But again, these things can occur in people who have gastric surgery, and for the most part, they look like B12 deficiency, except that they aren't. So infections causing maternal anemia, typically in the more developed world, is not an issue at all. Fetal infections like CMV or parvovirus or whatever don't cause maternal anemia typically. I mean, they can occasionally, but not usually. Again, it's an issue in the less developed world, and things that you can run into particularly in the less developed world that produce maternal anemia as infections are malaria and helminthic infections. And that's a little bit outside the scope of the talk. Hemolysis would be the last category. I'm not going to talk about hemoglobinopathies and thalassemias. If you eliminate them, there's basically three things that you're running into. Kind of garden variety autoimmune hemolytic anemia, Coombs positive hemolytic anemia, in other words. There's an entity called pregnancy-induced hemolytic anemia, and then there are the thrombotic microangiopathies. So standard autoimmune hemolytic anemia, again, is typical Coombs positive hemolytic anemia. If it appears early on in pregnancy, it was probably pre-existing. Again, standard is typically pre-existing. How do you manage it? You usually manage it, well, you manage it with the usual sort of things, immunomodulation. Steroids and IVIG are the best established ways of doing it. You'll need to get a hematologist to do this for you. There are a lot of things that are very popular in the hematology business for the management of autoimmune hemolytic anemia that are not clear that they're safe in the situation of pregnancy. For example, rituximab, which is a anti-CD20. In many cases, I sometimes think that you could write a very short book of benign hematologic indications for which rituximab is not utilized. But in any event, it's very popular in ITP and in autoimmune hemolytic anemia. It's not clear it's safe in pregnancy because of its potential effects. It does cross the placenta, and it may impede the ability to effectively immunize the child once born because it knocks out your CD5 immunity entirely. So now, in ITP, which a lot of the time we think of physiologically very similar to standard autoimmune hemolytic anemia, the baby's low platelets are generally less of an issue than the mom's. However, in autoimmune hemolytic anemias, the child may also experience severe anemia, much more commonly than a child of a lady with ITP has severe thrombocytopenia. So it's a significant issue. And again, standard treatment would be steroids and intravenous immunoglobulin. Okay, so then there's an entity called pregnancy-induced hemolytic anemia. It is likely not an entity. It is likely a bunch of things. It typically occurs in the third trimester. Some of these are Coombs positive. That's the fact that it occurs in the third trimester is what distinguishes it from what I was just talking about, kind of standard autoimmune hemolytic anemia. You treat it with steroids and IVIG just like you did before. The problem is that unlike people with a pre-existing autoimmune hemolytic anemia, people whose hemolytic anemia comes on in the late stages of pregnancy have a less good response to things like IVIG and steroids. It is still worth treating them, but they're whereas you can probably get 60 to 80% of standard autoimmune hemolytic anemias into a remission fairly easily. It's more like about 30% in this circumstance. Typically, it resolves about within 2 months postpartum. It has been reported to last as long as 5 months. It's the infant, again, will have anemia just like we talked about before. It generally clears up in several weeks which suggests it is an induced antibody of mom's. But it typically, again, we're running a little low on the edge here, and this is important points. One of the things that makes it different from standard autoimmune hemolytic anemia is it typically recurs in subsequent pregnancies. So if you have a hemolytic anemia that develops in the third trimester, following these patterns, there is a high likelihood it will recur. Not 100%, but it's a high likelihood it will recur in subsequent pregnancies. The biggest predictor of this is having had it in a previous pregnancy. So then moving on to HELP, TTP-HUS, you all know more about HELP than I do. These other syndromes are more easily are separated out on the basis of clinical issues. All of them will have some microangiopathic changes. Both HELP and HUS will have some reduction in ADAMTS13, which is the pathogenic mechanism in TTP. It's also a marker of vascular damage. It's usually slightly decreased in the HELP folks. It is very variable in HUS, may be severely decreased. The TTP people will have virtually absent ADAMTS13, and they will have typically antibodies against ADAMTS13. Again, the HELP people will have abnormal liver functions. The other folks won't. All of them will have some schistocytes. All of them will have low platelets. TTP people may have neurologic problems. HUS people predominantly have renal problems. HUS is typically postpartum. TTP typically starts in the second trimester. So in terms of, and when I was cutting this out of my chapter, it occurred to me that for the next edition, I need to make sure we get that, we don't have as big a gap there in that line, but any event. So, I mean, you know what to do with HELP better than I do. What do steroids do in HELP? They improve the laboratory features, but they don't necessarily improve the clinical outcome. What do you do with thrombotic thrombocytopenic purpura? You do exchange transfusion and support. Typically, we as a hematologists have a prejudice against giving platelets to people with TTP. The reason is, first, if you can get an exchange transfusion going, or even plasma infusion, if you can't get exchange transfusion in a hurry, the platelets will typically go up. Second, there is some data to suggest that because TTP is kind of a state of excessive platelet activation, that if you transfuse platelets, you may make it worse. There is some literature to suggest that people who get transfused platelets who have TTP get cerebral thrombosis at a higher incidence than people who don't get platelets. Now, every hematologist at some point or other before a diagnosis became clear treated a patient with TTP. Gave TTP to a patient. Gave platelets to a patient with TTP. It happens. Most of the time, hardly any of us have seen anything much bad happen with them. That's, of course, you know, we also have driven over the speed limit and nothing bad happened either, but that doesn't mean it's the right thing to do. The part of the reason why the association between cerebral thrombosis and platelet transfusion in TTP may be erroneous is because, well, what's the other predictor of having cerebral thrombosis? Really low platelets. What's the reason you would give somebody platelets? Really low platelets. So it may be an epiphenomenon, but it's generally frowned on. So the other HUS, which is now tending to be called complement-mediated thrombotic microangiopathy, and I use HUS because if I called it this, you wouldn't know what I was talking about, and neither would most other people. You treat them with support, dialysis if necessary. Eculizumab, which is a complement 5A inhibitor, may be a benefit. Is very useful in a typical HUS. It's also the treatment of choice for paroxysmal nocturnal hemoglobinuria. There are a number of small studies which say it can be safely used in pregnancy. Of course, this is, again, mostly a postpartum problem, so hopefully that wouldn't be an issue. Moving on, marrow failure states. That these do occur in pregnancy. Aplastic anemia, pure red cell aplasia, which may be associated with pregnancy, or may be pregnancy induced, or they may just happen to be hitting at around the same time or have been pre-existing. 25% of cases of pregnancy-associated aplastic anemia, at least, recur with subsequent pregnancies, so they are likely related in some kind of pathophysiologic, probably autoimmune mechanism. So how do you suspect these? You suspect it when you have a significant normocytic or mildly macrocytic. When I say mildly macrocytic, up to 105 MCV with very low reticulocyte response, usually 0.1% or less. So, if you say it's less than predicted, I would have predicted they should have 3%, they have 1%. That's not one of these things. That's probably folate deficiency. But anyway, and they have no readily available evidence of another anemia. With pure red cell aplasia, as the name suggests, you have anemia only. With aplastic anemia, you will typically have thrombocytopenia and neutropenia. You may have some evidence of mild hemolysis, suggestive of paroxysmal nocturnal hemoglobinuria. If you did flow cytometry for PNH, you might find a clone of cells that express it, but that doesn't mean you necessarily have PNH. It could mean you just have aplastic anemia. And the diagnosis requires a bone marrow examination. Again, bone marrow examination can be done safely in pregnancy. It is just inconvenient and unpleasant. Obviously, in this kind of circumstance, the necessity to make a diagnosis would offset that. It's largely a question of effective positioning and good local anesthesia. So how do you manage it? Again, this is managed by a hematologist sort of thing. The usual management would be aggressive immunosuppression and possibly marrow transplantation. During pregnancy, what most of the hematologic literature says is to support the pregnancy and then after delivery pursue a definitive treatment. If you have a significantly sized PNH clone in aplastic anemia, you could potentially think of using eculizumab, the complement inhibitor I talked to you about a few minutes ago. And again, it can be safely used. Now, with eculizumab, although unlike rituximab, there hasn't been any particular comment on vaccination efficacy, and we don't know, for example, how it would affect the child's ability after delivery to deal with complement-mediated infections. So, for example, we have to, before you give anybody, a patient eculizumab, you have to make sure they're vaccinated against meningococcus and H flu and a couple other things. So we don't know at this moment what sort of shape the child would be when you got around to that. My guess would be they might be impaired in their ability to address encapsulated organisms. So, any event. So it's also important to remember as we conclude that pregnancy does not prevent any etiology, does not protect you from the etiologies of anemia that you could develop when you're not pregnant. So in any event, that wraps it up, and I thank you very much. Yes. That is something, the vast majority of the problem with post-surgery like that is iron and B12. That accounts for 90-something% of it. They also do tend to have significant micronutrient defects. However, if they're not manifesting themselves, then I don't think you necessarily need to pursue them unless the patient developed anemia. Yes.
You see, there's a couple of small studies that talk about, I think most of the women who have physiologic pregnancy with the roadblocks take normal doses of iron supplementation like that. And the finding was they had higher rates of preterm delivery secondary to preeclampsia and higher rates of preeclampsia.
Yeah, I have, the answer is I'm aware of that. I haven't looked at them in detail. To be honest, I can't think of an iron-related reason why that would do that. Generally, even people who have disorders of iron metabolism that would promote that, where you would get toxic from standard doses of iron, it's decidedly uncommon, and I can't quite think of a reason why that would do that, because again, you're really not going to absorb much more iron unless you have hemochromatosis or some allied disorder. You're really not going to absorb much more iron than you need. Yes.
Maybe you're
people who use iron skillets don't generally have iron deficiency anemia.
Okay. Well, no, I'm glad you mentioned that because that is a common thing, and it is not unusual for me to get, over the years, it has not been unusual for me to get referrals from generally non-physician-run clinics that will have and a person will have iron deficiency, will be diagnosed with iron deficiency, and they'll be sent to me to give them IV iron, for example, and they will have a handout that they were given, and it will recommend that they do their cooking in an iron skillet and this kind of stuff. And the answer is, I suppose it certainly doesn't hurt, and many things you cook in an iron skillet taste better. Cornbread, for example. But the answer is the amount of iron that you absorb from that is minimal. Part of this derives from, there's a lot of things that are kind of related to that kind of thing. It probably doesn't hurt, but I don't think I would not treat iron deficiency with get rid of your Paul Revere cookware and go to Cracker Barrel and buy a bunch of iron skillets. But the extent to which like cookware affects iron absorption is I think largely mythical. There is, for example, you probably, most of us at one point in medical school were probably told about the Bantu in Africa and how the Bantu get hemochromatosis because they make beer in iron pots. And so the Bantu, yes, the Bantu have a high frequency of hemochromatosis. It used to be called Bantu hemochromatosis, now it's called African siderosis. But in any event, yes, the Bantu do have an unusually high incidence of hemochromatosis. Yes, the Bantu do make a sorghum-based beer, which sounds dreadful, and they do cook it in iron pots. The Bantu also have a defect in their iron metabolism genes. So it's the second. The fact that the iron pots probably doesn't hurt, but it doesn't help much. But in fact, it's the genetics. And so there's also hemochromatosis is the most common genetic illness genetic disorder in Northern European populations. And there's a very high frequency of heterozygosity in it, for example, in this neck of the woods. And it may be that if you happen to have hemochromatosis, you happen to have an abnormal hemochromatosis gene, and so you're going to be less likely to get iron deficient, and you may absorb a little bit more of the iron that's in your food. But I don't recommend that people. I like a high meat diet myself, but I don't think it's protecting me from iron deficiency. Yes.
I've heard the recommendation a few times that you should get vitamin C to help iron absorption.
Okay, so the answer to that's not a myth, but it's probably not. I have rarely found it necessary. So if you have an acid stomach environment, then you will absorb iron better. And vitamin C is kind of a socially acceptable way to get your stomach a little on the acid side. Most people who are otherwise healthy don't need it. If you're an older person, you actually could argue you've got a little bit of, you're 80 years old, you have some achlorhydria, it might be helpful. The answer is it increases your iron absorption slightly. I am not aware of any good study that compared it with and without that wasn't complicated by things like the vitamin C people were taking it with food and this kind of stuff. So where I think vitamin C may be useful is if you had somebody, iron absorbs much better if you take it on an empty stomach. Doesn't have to be empty for 2 hours. Doesn't have, but you know, if you take it, you know, I tell people to get up in the morning, take their iron, and then you know get ready and then eat. If the patient insists on you know taking their iron with food, then I think that's not an unreasonable thing to do. It certainly does no harm. It may help, but it may help a little. It probably doesn't help significantly. Okie doke. And one question would be, could you then take your iron skillet and pour orange juice in it, and then cook?